Welcome to the Crohn's and Colitis Foundation Professional Education Webinar Series. We welcome distinguished faculty, Dr. Miguel Regueiro, Dr. Katie Falloon, and Dr. Shubha Bhat, all from the Cleveland Clinic Inflammatory Bowel Disease Center, to discuss new treatments in IBD. They will discuss new medications for IBD, positioning, real-world evidence, and the Foundation's EMR IBD education tool. Please type any questions that you have in the chat, and we will cover those in our Q&A at the end of the webinar. I also want to let everyone know that recordings of all of our webinars and over 250 IBD training modules for healthcare professionals can be found on the IBD Clinical Hub at crohnscolitisprofessional.org. Without further ado, I will hand this over to Dr. Regueiro.
Great. Well, thank you very much. Again, I'm Dr. Miguel Regueiro. I'm professor and chair of the Digestive Disease and Surgery Institute and professor of medicine at Cleveland Clinic in Cleveland, Ohio. And it's my great pleasure to present today for this Crohn's and Colitis Foundation program on new treatments in inflammatory bowel disease, and really get into aspects of positioning IBD advanced therapies today and tomorrow. I'll be joined by Dr. Katie Falloon, one of my colleagues here at Cleveland Clinic, as well as Dr. Shubha Bhat, who is our IBD pharmacist as well. So these are our disclosures. I'd like to take you briefly through the timeline of inflammatory bowel disease therapies. And it's interesting to think that not too long ago, we were somewhat limited in the treatments we had that included corticosteroids, 5-aminosalicylates, and then you can see into the 1980s to 1990s, really thiopurines. It wasn't until 1998 that the first monoclonal biologic, infliximab, came to market. And then you can see as we go further to the right on this graph, both for Crohn's disease, which is on the top, and ulcerative colitis on the bottom, we've had literally an explosion of therapies that we now have for the treatment of inflammatory bowel disease. I should mention at the time of this presentation, upadacitinib was also just approved for Crohn's disease, so for both Crohn's and ulcerative colitis, and we'll come back to that in a minute. I wanted to give an IBD landscape overview. And as you think about the therapies to use for the advanced treatment of inflammatory bowel disease, we need to take a personalized approach. So this is somewhat of a summary of our current therapies. So we have the TNF inhibitors, which include 4, infliximab, adalimumab, certolizumab, golimumab. These are given intravenously or subcutaneously. They have a very fast onset of action. Usually these are best when we combine them with an immunomodulator, such as 6-MP or azathioprine. They're also very good at extraintestinal manifestations, joint and skin manifestations of IBD. And we've also used these for perianal disease in Crohn's, like fistula or abscesses. These do have a component of immunogenicity, antibodies against the therapy. Infections can be a risk, and rarely things like malignancy or lymphoma. The anti-integrins were the next category of medicine. Really, vedolizumab is the primary that we use today. Currently is available as intravenous, but coming soon in the United States will be a subcutaneous form. These are better when we use vedolizumab as the first-line therapy before other treatments. Vedolizumab has low immunogenicity and an excellent safety profile, primarily because it is gut selective. More recently, we've had anti-interleukin 12 and 23, which is ustekinumab, and anti-IL-23, which is risankizumab. These are given intravenously and then subcutaneously for maintenance. These have a fast onset of action. These are effective both in TNF inhibitor naive patients or if a patient has already been on an anti-TNF. These also have low immunogenicity. These are uniquely positioned in patients who have psoriasis or psoriatic arthritis and also have an excellent safety profile. Some of the newer therapies are the oral small molecules. The Janus kinase inhibitors include tofacitinib, and then more recently, upadacitinib. Initially, these were only available for ulcerative colitis. However, a footnote to this slide should be that these are now, upadacitinib at least, approved for Crohn's disease. These have a fast onset of action, good efficacy in patients who've been on a TNF inhibitor, no immunogenicity, also good in patients who have joint manifestations. There are some side effects that include herpes zoster or shingles, and we recommend Shingrix vaccine before these. And in rheumatoid arthritis, there have been some initial concern over cardiovascular events and blood clots, which we have not seen in inflammatory bowel disease. And then finally, the S1P oral small molecule ozanimod, given orally for ulcerative colitis, best in TNF inhibitor naive patients, no immunogenicity, also used for multiple sclerosis with a good safety profile. So there are the number of these emerging therapies in IBD, and this is really not to go through this slide in detail, but just to give you a sense of the overall what is on the horizon. And I think a lot of the hope and excitement for our patients that there are better and better therapies to come. So with that, I'm going to go ahead and hand it over to my colleague, Dr. Katie Falloon, who's going to take you through the next portion of the presentation.
So thank you so much, Dr. Regueiro. Now that we've had a great overview from him covering available and emerging advanced therapies for IBD, we'll focus in on when and how to use these agents. I will talk with you about treatment of ulcerative colitis, and then Dr. Bhat will cover treatment of Crohn's disease. So the first question to address with respect to treatment is when to start it. And the answer is as soon after diagnosis as is possible. If you look at these diagrams with time on the x-axis and digestive damage on the y-axis, you can see that certainly for Crohn's disease and likely for ulcerative colitis as well, the more time that passes without treatment, the more digestive damage accumulates. And there is a window of opportunity highlighted in orange here when the disease is still early in its course and the damage is more minimal, in which we can gain optimal disease control. By doing so, we can prevent disease progression and complications that often can't be managed with medical therapy. Because that window of opportunity is limited, we want to select the right therapy for each individual patient in induction, so we aren't wasting time adjusting therapies while disease continues to progress. Again, this diagram was developed for Crohn's disease, but it is applicable to our ulcerative colitis patients as well. Typically, advanced therapies are started later in disease course when complications are already present, such as fistulas or abscesses in the case of Crohn's disease, or things like steroid dependency or hospitalization in the case of ulcerative colitis. And we really want to be starting the optimal therapy, which is advanced therapy in the case of moderate to severe UC here, right after diagnosis and before progressive damage occurs, and we're talking to patients about things like colectomy. It's also important to think about what our goals of therapy are and how we will see if we've met them. There are a number of treatment targets we look at, starting with clinical remission, which is achieved when the patient is no longer having diarrhea or blood in their stool and is overall feeling well. It is important to keep in mind, however, that patients with IBD can have other coexisting GI conditions, including disorders of gut-brain interaction, that can cloud the clinical response picture. We can also look at more objective targets, including biochemical markers, such as C-reactive protein or CRP, and also fecal calprotectin. Fecal calprotectin we often check around 3 months after starting a new therapy to assess response. Even more rigorous is endoscopic remission, where we're really looking at mucosal response and normalization to at least Mayo 1, if not Mayo 0 disease, ideally with no evidence of ulceration or erythema in the colon. We often perform endoscopic evaluation around 6 months after starting a new UC therapy to assess for endoscopic improvement or remission. And this target really is important. Data suggest improved outcomes when we reach endoscopic remission, including decreased need for hospitalization, steroids, colectomy, and even decreased risk of development of colorectal cancer. Finally, an emerging target is histologic remission, for which different scoring systems are used, but really the overall goal is that when you take a biopsy from the colon, even under the microscope, you're not seeing any evidence of ongoing disease activity. So how do we hit these various targets? Our treatment strategies are really driven by the risk of complicated disease. And for ulcerative colitis, we can divide our patients into two categories. Low-risk patients are those with limited anatomic extent and mild endoscopic disease. And these are patients who are appropriate for 5-aminosalicylates as maintenance therapy. On the other hand, we have patients at high risk who are really good candidates for early advanced therapy. High-risk features include young age, so our patients under 40, extensive colitis, deep ulcers, steroid dependency, prior hospitalization, high inflammatory markers, and prior infectious complications, including C. diff infection and then CMV infection, which is found on colonic biopsies. So once we've decided that a patient needs advanced therapy, how should we decide which therapy to use first, second, third? What do we position when? Unfortunately, the quality of evidence here is more limited, with only one head-to-head study and the remainder network meta-analyses. And these aren't perfect, but they're really the best that we have. So we'll spend the next few minutes going over this literature. First, we'll discuss the head-to-head study called the Varsity trial. This was a randomized control trial of vedolizumab versus adalimumab in patients with moderate to severely active ulcerative colitis. The study incorporated 245 centers across 34 countries. It included a total of 769 patients. There were 383 who received vedolizumab and 386 who received adalimumab. And the primary outcome was clinical remission at week 52, and the secondary outcome was endoscopic improvement. As you can see here, overall, vedolizumab in the red was superior to adalimumab with respect to achievement of clinical remission and endoscopic improvement, and this persisted across TNF-naive and TNF-exposed patients. However, there are important limitations to keep in mind here. Dose escalation was not permitted and drug levels were not followed, which is a departure from real-world clinical IBD care and how a lot of us practice, and this could have important implications in the interpretation of this data. In addition, with the use of steroids or immunomodulators, no difference was seen between the groups, which is also important to keep in mind when you're deciding which of these two therapies to use first. We'll move on now to our first systematic review with network meta-analysis. Keep in mind that, again, the data here is not as robust as a head-to-head trial and needs to be interpreted with caution because this is a network meta-analysis. However, with that caveat, when you look at first-line induction pharmacotherapy for moderate to severe UC, you can see that all agents examined in this review, so infliximab, adalimumab, golimumab, vedolizumab, and tofacitinib, had a positive effect size compared to the control groups. This means that basically no matter which therapy you select, you're giving your patients a better chance of achieving remission than if you didn't treat them at all. However, if we're looking at which agents had the best data supporting their use, infliximab and vedolizumab are the two. They had the strongest data for induction of clinical remission and mucosal healing, again, based on indirect comparisons. Vedolizumab was also noted to be the safest in this study. So highlighted here is a more recent systematic review that incorporates some of the newer agents already discussed by Dr. Regueiro. A total of 28 trials were eligible for inclusion with a total of 12,504 patients, and endpoints were clinical remission at week 6 to 14, depending on what the study endpoint was. And as you can see in the forest plot here, for all patients, UPA and infliximab ranked first in clinical efficacy. For anti-TNF patients, the findings were the same. And then for anti-TNF exposed agents, UPA was superior to all the other agents. When we move from clinical efficacy to endoscopic improvement, there were 27 trials with 11,733 patients and the same week 6 to 14 endpoints, again, depending on the study. And overall, infliximab dosed specifically at 10 milligrams per kilogram ranked highest for the endoscopic improvement endpoint. And so subcohorts of anti-TNF naive patients and anti-TNF exposed patients, notably with ozanimod excluded, UPA ranked the highest. Reassuringly, in this study, no one agent was significantly more likely than placebo to lead to a significant adverse event. And in some cases, specifically for Veto and golimumab, the risk of significant adverse events was lower than placebo, highlighting the favorable safety profile of advanced therapies and the risks associated with untreated ulcerative colitis. UPA was the most likely to lead to adverse safety events, and ustekinumab was the least likely in this study. And then with respect to infections, TOFA was ranked last. I'll wrap up my portion with data from the most recent systematic review published just last year in Lancet Gastro Hep. It included 29 studies looking at efficacy and safety of biologics and small molecule drugs for patients with moderate to severe UC, with the primary outcome of clinical remission. The authors used the surface under the cumulative ranking, or SUCRA, to rank the included agents, with higher scores correlating with better efficacy and lower scores with better safety. And you can see the rankings for clinical remission and endoscopic improvement here. And I'll just highlight for you that UPA, once again, was found to be highest for induction of clinical remission. It also was found to be highest for adverse events. And then vedolizumab ranked lowest for both adverse events and serious adverse events. So that is all I'll cover for today. I'm going to hand it over to Dr. Shubha Bhat, who's going to talk with you about treatment of Crohn's disease.
Thank you, Dr. Falloon, for a very comprehensive overview on the treatment data and considerations as it relates to ulcerative colitis. I'm going to take a similar approach, except focus on Crohn's disease. As we do in ulcerative colitis, we'll also use a treat-to-target approach in Crohn's disease, with the target being remission. For clinical remission, there are several metrics that we use to identify whether patients have attained symptom control. It's the Crohn's Disease Activity Index, as well as the Harvey-Bradshaw Index. For the CDAI, if the score is less than 150, and for Harvey-Bradshaw Index, or HBI, if the score is less than 5, we would consider a patient to be in clinical remission. There's also patient-reported outcomes, and as long as the patient's not reporting any diarrhea or pain, this could be another metric that we could use to determine if a patient is in clinical remission. Now, as we've seen with inflammatory bowel disease, clinical remission is not a metric. It's not the only metric that we can utilize, because clinical symptoms don't always correlate with ongoing inflammatory burden. And to that point, we now have biologic remission, which not only accounts for clinical remission, but will also account for physical evidence of inflammation as seen by endoscopy and cross-sectional imaging. For endoscopic remission, we're basically looking to make sure that there's no appearance of any lesions, any ulcerations, or any narrowing. And we also have several metrics or scoring systems that the gastroenterologist performing the endoscopic procedure can utilize to determine if a patient has attained endoscopic remission. And unlike ulcerative colitis, there's actually no clinically validated metric that we can use to identify histologic remission. Actually, per STRIDE 2, it is unclear if histologic remission should be a targeted area right now, but we can actually look to see if a patient maybe has clearance of transmural inflammation. So all in all, these are basically the 4 categories that we can use to define to see if a patient has attained remission within Crohn's disease. So not only do we have treatment goals that we're looking to target, but we also need to take into account patient factors, as these can help predict the risk of complications that can come along with Crohn's disease. And to further put this into perspective, so if we have a patient that is greater than 30 years old at initial diagnosis, they don't really have much inflammatory involvement anatomically. There's no complication or classification of severe disease, such as perianal or severe rectal disease. They basically have superficial ulcers. They don't have any history of surgery or stricturing or penetrating pattern. We would classify this patient to be at very low risk for disease complication. And to put this into perspective, this might actually be a great patient that if they are presenting with symptoms, but endoscopically they don't seem to have a ton of inflammation, maybe they might be a great candidate for budesonide for at least 8 weeks. Conversely, if you have a patient that has those opposite criteria, so they're diagnosed when they're less than 30 years old, they have extensive anatomic involvement, they have complications of disease already, such as perianal or severe rectal disease, they have deep ulceration, they have prior surgical resection, or they have stricturing or penetrating pattern of inflammation, this is a patient that we consider to be at high risk of more than 80% of having rapid progression of Crohn's disease. And so for this patient population, we need to make sure that we're utilizing early advanced therapies. And so this is a concept that time over time we will continue to see. And essentially what we know is that not only is it important to aim for the correct treatment goals, it's also important to make sure that we're timing the initiation of effective therapies early on. As you see here on the diagram, is that if we let the inflammation progress, it does get to a point where complications can develop, but moreover, inflammatory burden will increase and it makes it a lot harder to treat. Thereby, if we can start advanced therapy that's first line in a moderate to severe patient with Crohn's disease and we start it early on, the treatment will be a lot more effective because we're preventing the complications from occurring, but we're also minimizing the inflammatory burden that can develop later on, which then makes it harder for treatment to work. And unfortunately, based on our current practices, we typically will start advanced therapies a lot more delayed. And again, getting back to the point that therapies don't usually tend to be as effective compared to if we were to initiate them earlier on in the disease course. So main take-home point here is to start advanced therapy before the damage occurs. So how do we position the treatment based on the options that we have currently for Crohn's disease? As of right now, we only have one head-to-head study, which is a CView study that is available for Crohn's disease, and we will talk about that study in a second. But ultimately, really what's helping us guide or position our treatment right now is currently a network meta-analysis. It's not the best. Obviously, there's limitations with this type of methodology, but it is a resource that we have, and so this can definitely help position how we tend to use medication, specifically in patients with Crohn's. So the CView study was a randomized controlled double-blind study, phase 3 trial that occurred in over 18 countries. And the study specifically included patients that were 18 years or older that were actually biologic naive. So these patients never had any biologic exposure. However, they had been exposed to conventional therapy and they either failed it or were considered to have intolerance to these therapies. Additionally, to be included in the study, the patients also had to have one ulceration, irrespective of size, that was found on the initial baseline endoscopic evaluation. And so the patients that were ultimately enrolled into the study were then randomized to either receive ustekinumab at the standard dose or adalimumab at a standard dose for up to 52 weeks. And essentially what they found in regard to the primary endpoint was that they were looking to see what proportion of patients on each treatment were able to achieve clinical remission, and this was defined as having a Crohn's disease activity index of less than 150 at week 52. And as you can see here, that we had about 61% of patients on adalimumab that achieved this primary endpoint compared to about approximately 65% of patients on ustekinumab. Statistically, there was really no clinical differences. So at the end of the day, the main take-home point that the study found in this head-to-head study is that both adalimumab and ustekinumab are acceptable choices for patients that are biologics naive and have moderate to severe Crohn's disease. So moving on now, I would like to focus on the network meta-analysis, and this was published in 2018 by Singh et al. The intent of this network meta-analysis was to perform a comparative efficacy and safety comparison in two patient populations. The first, they looked at biologic naive patients, and then they looked at patients that have been exposed previously to an anti-TNF therapy. And so this slide here particularly applies to the first-line induction, so patients that had never had any biologic exposure. And as you can see here from the statistical analysis that was completed, the options that are appropriate for first-line induction was that both infliximab and adalimumab scored the highest, or they ranked the highest. But that being said, vedolizumab and ustekinumab are also appropriate options. So main take-home point here is that in a patient that's biologic naive, infliximab, adalimumab, vedolizumab, and ustekinumab are definitely reasonable treatment options. As you can see here, adalimumab did not perform as well, so compared to control. So this might be a potential agent to maybe not consider, but keep in mind, again, there are caveats to applying systematic review to practice, and that there are study heterogeneity that can be sometimes hard to control. However, again, this is a methodology that is available, especially when we don't have a lot of head-to-head studies to work off of. So the next patient population that this systematic review then looked at was to see what medication would be best in patients that have had prior anti-TNF exposure, particularly after infliximab. And so this is deemed to be the second-line agent. And as you can see here, in terms of the findings of this network meta-analysis, found that both adalimumab and ustekinumab performed well. Adalimumab compared to control was not found to be like super effective after infliximab initiation. So there was an updated systematic review and a meta-analysis that was completed in 2021 and involved phase 2 and 3 randomized controlled trials that were done in adults with moderate to severe Crohn's disease, classified as having a CDAI index of 220 to 450. And this included a population of patients that were both biologic naive as well as biologic experienced. And what you can see here was that from the network meta-analysis, they're basically found to be moderate confidence and estimate supporting the use of infliximab monotherapy, infliximab with combination, particularly with azathioprine, adalimumab or ustekinumab over adalimumab for the induction of Crohn's disease remission. And then in the biologic exposed patients, the network meta-analysis supported the use of ustekinumab or risankizumab for induction of clinical remission. You'll see here that adalimumab was actually noted to rank the highest for this endpoint, but these findings were actually influenced by the inclusion of the GAIN trial. This study was a study that actually recruited patients that had secondary loss of response or intolerance to infliximab, and they only had to have one biologic failure. And as you know, in other studies, particularly for ustekinumab and risankizumab, those studies have actually included patients that have failed several biologics. So there is a potential confounder here, and that the adalimumab population or studies that were included may have not necessarily had as much biologic exposure as some of the other studies that were included. So that being said, we know that adalimumab or risankizumab or ustekinumab may be potential treatment options. However, given what we know about pharmacokinetics and pharmacodynamics of today's time, particularly for anti-TNF, in the setting of when we have mechanistic failure, it makes most sense to switch to an alternative medication class with a different mechanism of action. And so the authors concluded that from these findings, adalimumab after infliximab loss of response or risankizumab or ustekinumab would be best as second-line therapy for the induction of clinical remission. And then lastly, though we talked a lot about induction, what about maintenance of clinical remission in patients with moderate to severe Crohn's disease? And so within this particular cohort of patients, the network meta-analysis found moderate confidence and estimates supporting the use of basically all biologics over placebo. So there was really no one medication that was found to be superior. So we talked about the induction of clinical remission. What about the maintenance of clinical remission in Crohn's disease? And what this network meta-analysis essentially found was that there's moderate confidence and estimates supporting the use of biologic medicines over placebo for the maintenance of clinical remission in moderate to severe Crohn's. The network meta-analysis did not find any one agent to be superior over the other. But the main take-home point here is that basically all biologics were found to be effective in supporting for maintenance of clinical remission. So there's a lot of content to digest overall, and I think that one main take-home point is that we definitely need more studies, more head-to-head studies to better help us position how to use the available agents that we have. Since the time of the study that we currently discussed on the slide, there have been emergence of more additional data as well as newer treatment options. And so we're looking to see if there's going to be more additional studies down the line to better help us determine how to use these effective agents. And so before I hand it back over to Dr. Regueiro, I would like to highlight one tool that is being offered by the Crohn's and Colitis Foundation, which is the Electronic Medical Record, or EMR IBD education tool. This is essentially a tool that will help populate a certain text within your EMR And there's currently 46 topics that are available, which we'll provide an overview of in the next slide. But this can basically be a resource that you can integrate into your workflow, and it can be served as a great education material for patients. The Crohn's and Colitis Foundation is committed to expanding upon this resource, so if there is any additional topics that you would like to see, definitely reach out and let them know. You'll see that the link for the EMI tool is listed below on the slide, and when you click on that and get onto the website, there's actually an option to provide additional insight, to provide additional suggestions for a potential topic. And so as mentioned before, here are the list of the 46 topics that's currently available within the EMI IBD educational tool. You'll see that it's primarily broken down into medication therapy topics as well as disease-related topics, and some of the content within the disease-related topics include, for example, extraintestinal manifestation, anemia, and the role of labs. So again, this is a great resource that if you can integrate into your workflow, it's already pre-text, it's kept up to date, and it can be a great educational resource to provide patient education. And I'd like to provide an example of what that IBD EMI education tool looks like. And here's an example for ipitastinib. And this basically, once it's pre-text into the EMI, this is what will populate. And so it will provide the patient information about how the medication works, how it's taken, potential possible side effects that can occur, special consideration, monitoring parameters, as well as other additional points or other additional information to know. And so it's a very comprehensive guide that's already designed and kept up to date, and can be very easily integrated into your EMI. And so I'd like to conclude one final point before I hand it back over to Dr. Regueiro. We talked a lot about the potential treatment options, how to position them, and as well as the treat to target strategy. However, keep in mind that at the very end of the day, we need to make sure that we're individualizing our approach for the patient, but moreover, making sure that we're keeping up with ongoing monitoring. So in the treat to target, we're going to start the patient on their initial treatment. We're going to assess to see if they're meeting their target. We'll adjust their treatment accordingly. We'll continue to assess if they're meeting the target. And even if they do reach their target, we're going to provide ongoing monitoring. And I'd like to highlight that there are several monitoring parameters to consider. So first, we should be utilizing any scoring tools that incorporate the patient's perspective. So for example, the patient-reported outcome. We talked a lot about how clinical remission is not the only primary endpoint because that's not always the most reliable marker. So we'll need to include imaging and procedures to make sure that internally inflammation is being controlled. And so this might involve a CT scan and MRI, endoscopic procedures. On top of that, we should also keep an eye on blood work. The hemoglobin is another great marker that can, if a patient's anemic, could be a sign of ongoing inflammation. There's also fecal calprotectin, C-reactive protein. These are some additional blood work and stool studies as well that we can incorporate to assess for how inflammation is being controlled. We should also be assessing for any extraintestinal manifestations, because this can definitely have a significant impact on patient quality of life. Sometimes the treatment can go hand in hand for what we use for inflammatory bowel disease. Other times we may have to kind of come up with a dual treatment strategy. So keeping an eye on this and seeing to make sure that we're getting the patient under complete control. And then lastly, we should also definitely keep an eye on the growth and overall development. When patients are flaring, that there's potential for significant weight loss, for example, and so making sure that patients are able to attain their goal weight and essentially are able to continue in terms of being in normal development. So with that, I would like to now hand it back over to Dr. Regueiro.
Well, great job, Shubha. Thank you very much. And I think you've set up my final part of the presentation nicely to talk about safety. So we want to consider safety when we look at our medications and options for our patients. And our patients often will come in asking about safety. They've read about it on the web. These are obviously important questions that they have. We originally, our group looked at a safety pyramid, and I should mention up front that we published this initially in 2019 in the Inflammatory Bowel Disease Journal, and this was meant as a visual way to consider medications. It's not necessarily evidence-based. I want to be careful to say that. It's the way I interpret safety. And this is initially the pyramid in 2019, and I'll show you the pyramid more recently. And this is looking at the safest medicines on top. So you can see initially when we came out with the pyramid, vedolizumab and ustekinumab were on top. I should mention at the very bottom, the least safe medicine, and I think we realize this now, is that steroids. So using steroids repeatedly or long-term are not a safe option and are probably the least safe medicine that we have. It's also important to know that inadequate treatment is an adverse event. The reason I say it that way is that even though in the green at the very lowest part of the safety pyramid, I put thiopurine and anti-TNFs, in a minute you'll hear me say sometimes our best treatment for Crohn's and fistula is infliximab with thiopurine. And even though in the safety pyramid that's lower, that may be the best treatment. So don't undertreat our patients, and we should use whatever medicines we think are the best in terms of efficacy. Well, the safety pyramid evolved. I had another publication on this where at the top we include vedolizumab and ustekinumab really on parity, and you can see they're about the same. And then more recently, and this is actually a publication that Dr. Bhat and I and one of our other colleagues have in press with the Crohn's Colitis Foundation and Inflammatory Bowel Disease Journal, is our new safety pyramid of today. And this is how I would position it. So we have vedolizumab, the interleukins, which include ustekinumab and risankizumab, and the S1P molecule ozanimod. Those are really kind of at the top. And then our Janus kinase inhibitors below that, tofacitinib and upadacitinib. And I wonder, with upadacitinib being even more selective for Janus kinase 1, whether there's even an improved safety. And then you can see from down. I should say, again, this is our opinion. This is not evidence-based, but I think it gives you a visual way of looking at potential safety, or at least giving you a sense for discussion with patients. The other thing that I'll mention is sometimes, and I say this as a joke, but I'm serious, probably the best human biologic is colorectomab. Now, obviously, that's not a real medicine, but our colorectal surgeons are sometimes the most important part of the care of both our ulcerative colitis and Crohn's patients. And sometimes surgery is the best indication. And sometimes that's required even earlier in the disease course, maybe then followed by medicine. So let's not lose sight of that. And this is really my final slide. And I think this will summarize how I practice. And I know Dr. Falloon and Dr. Bhat, all of us working together, are somewhat similar. So biologics and small molecules today, which one do we use first? How do we sequence? How do we position? This is kind of our practice style. I will say that many times the payer or insurance company will require something like an anti-TNF first. And the FDA label for the JAK inhibitors, tofacitinib and upadacitinib, we must use a TNF inhibitor first in those patients. So let's consider some categories of patients and how we would position therapies. The first is for the severe ulcerative colitis patient, either in the hospital or sick enough that we're considering hospitalization. These are patients that generally, if they've never been on anything, we use infliximab, sometimes at the higher dose of 10 milligram per kilogram. And you heard me say earlier, I'll often combine this with azathioprine or 6-MP. If one of these patients have already been on infliximab, an anti-TNF, then this is where I think upadacitinib and to some extent maybe tofacitinib certainly play a role. We need more data on those in the hospital, but upadacitinib I think has a strong evidence that this works well in this population. What about the outpatient moderate ulcerative colitis? So maybe not that really sick, almost needing hospitalization patient. And I break it down into age. So over the age of 60, where maybe comorbid concerns of infection and cancer are higher, we really have some very good choices. First line vedolizumab, ustekinumab, or ozanimod as a small molecule. And I think those are some really good options. If they're younger than 60, again, same thing, vedolizumab, ustekinumab, or ozanimod, but then obviously we'll include the TNF inhibitors. For patients who've been on a TNF inhibitor with ulcerative colitis, you heard me say this a minute ago, I think upadacitinib has been my next line therapy. One other caveat, and you'll see that in italics there, ozanimod, I think, is uniquely would be positioned as an earlier treatment for ulcerative colitis after mesalamine or 5-ASA, maybe one course of steroids. So maybe ozanimod's best position is bio-naive, never been on any biologics, earlier in therapy. What about Crohn's disease? So Crohn's disease without a fistula, similar to what I just said, vedolizumab, ustekinumab, or risankizumab are all very reasonable. If it's a patient who's had fistula or more extensive disease, then I still think infliximab and an immunomodulator would be best. And let's remember, after a TNF inhibitor, at least in my practice, I'm using upadacitinib as possibly my next therapy. For extraintestinal manifestations, arthritis, erythema nodosum, which is a skin manifestation, really any of the medicines that heal the bowel inflammation will improve that. Our more difficult extraintestinal manifestation, pyoderma gangrenosum, uveitis, central or axial arthritis, again, we'll use TNF inhibitors first, but this is where, again, upadacitinib, tofacitinib certainly play a role. But for skin manifestations, ustekinumab and risankizumab work quite well. And then the final point is pregnancy. Really, any of the monoclonal antibody biologics are safe in pregnancy. We don't stop them. We continue to treat through. And even after pregnancy, for our patients that breastfeed, certainly these are safe therapies. We must stop methotrexate. That's the one that if a patient's on methotrexate, we really want them off that for at least 3 months. But with the small molecules, ozanimod, tofacitinib, upadacitinib, not enough safety data in pregnancy yet, so we don't recommend it in pregnancy, but patients should be off for about a month before they try to conceive. Thanks, everybody, for attending today. And now we really look forward to the question and answer session. Great. Well, thank you, everybody. Thanks again for attending this Crohn's and Colitis Foundation event, New Treatments in IBD, Positioning IBD Advanced Therapies for today and tomorrow. We really appreciate everybody. There's actually a lot of people online. We do see some questions that came through the chat. And at this point, we'll go ahead and have a discussion, and I'll kind of with Katie Falloon and Shubha Bhat, myself, talk about some of the questions that are coming in. As a reminder, and I see more questions coming in, which is great, feel free to chat in questions and we'll get through as many as we can. Katie, let me start with you. There's a question on ulcerative colitis and failing therapy, and the patient, as we see many times, I actually saw a patient today who really doesn't want a colectomy. I guess, how do you manage that? But the real question is, what happens if they've been on, or will you try all therapies? And maybe in the context I'll put, if they failed monoclonal antibodies, therapies, biologics, how much do you keep pushing? Kind of what are your thoughts on that?
Yeah, so thank you. A great question, and something that we do see very commonly. I think kind of the things that you have to think about are the severity of the ulcerative colitis, one, and then two, I like to get a sense of why the patient is reluctant to pursue a colectomy and what the barriers are. And if they do have severe disease and there's someone who's already been refractory to an anti-TNF, I'd like them to at least meet with the surgeon and get a sense of what the surgery would be, because we're starting to worry about whether or not they respond to something else. That being said, kind of as we talked about in the session just before now, there is some good data for UPA as an agent after patients have been refractory to anti-TNFs. And it has a quick onset of action also. So in somebody who would be a candidate who doesn't have any sort of absolute contraindications to that, that would be a good next step.
Great. And yeah, I'll just add to that. I mean, I think you and I practice very similarly. I think that's kind of what I would do, that, you know, first of all, make sure that we've used the term, sometimes we say, we want to make sure we help your life, your quality of life, and sometimes saving the colon, meaning not doing surgery, can be very detrimental. So as you said, it's understanding what are the fears over surgery. I think many of our patients understandably are concerned about a permanent ileostomy. And I think now with ulcerative colitis, the J pouch and the advancements in surgery are such that's something we would discuss. However, as you said, and from the upadacitinib ulcerative colitis data, there were patients in the study that had failed 3 or more biologics, as you kind of point out. And so I wouldn't close the door on especially the small molecule class, maybe even specifically upadacitinib as a treatment. Now, I guess if they failed all small molecules, all biologics, then we're a little limited, because the question is going back to something. Maybe if we have time, we can get into to use combination biologics or small molecule biologic. But for the most part, if they failed an anti-TNF and they failed, let's say, upadacitinib, that's a time we really have to understand what the barrier of surgery is, because those are the patients I think need surgery. Shubha, we have all these wonderful medicines, and we work with our payers all the time. And I know within our group, you've been wonderful at kind of helping with guidelines and guidance about what the approved medicines are for certain diseases, but sometimes we still get pushback. And there was a question about dealing with the challenges that we receive from insurance companies regarding the transition in therapies if there's an evidence of lack of remission. So kind of what is the wording? How do we approach that? What are you doing to help with the payers to get approval when we transition treatments?
Yeah, so excellent question. And I hate to say that we commonly deal with a lot of payer issues, right, in terms of trying to care for patients with inflammatory bowel disease. So one thing I would like to just emphasize is that documentation is critical. So when you're actually writing your progress notes, it's important to put in like endoscopic information, put in any patient-reported outcome measures or scoring tools that we use to see how symptomatically patients are feeling, and really documenting all their prior treatments that they have tried to further emphasize like where you are in their treatment course. So I think having that core documentation piece is the most essential part to really getting that treatment approval. Now, if the insurance is adamant and they say, no, you need to fail XYZ, or like this is not a preferred treatment option, then making sure that you attack the appeal process by really customizing that letter of medical necessity. So making sure that you're addressing exactly why the XYZ options are not appropriate, or why you're particularly picking that medication for that patient. And then making sure that you're citing with references, whether that's guidelines or any studies that you might have available. And I think, so hopefully through those two mechanisms, I think that's what we're typically doing in our practice, and we have a really good success rate with those approach. And I would like to also just add one additional plug for the Crohn's and Colitis Foundation, is that they actually have appeal letters available online. So I would definitely recommend checking out that resource if you're looking for a guide that's already written and that might further guide you.
Yeah, I think I'm happy you said that. Obviously, the Crohn's and Colitis Foundation with the appeal letters that are now available have been very, very helpful, and they're easy to upload, easy to use. I think obviously are written on a professional level where a lot of times that helps as a resource. The only final thing I'll say, and I agree with everything you said, is sometimes talking to the medical director on the phone from the insurance company. Interestingly, even though I understand it's a process, it takes time to get on the phone and make that connection. And believe me, I understand all of that. But sometimes when you do get through the medical director and you explain what's happening, the approval for that has been very high. I've not had many calls where I actually talk to the medical director, explain why we're doing something, that they won't approve it. And then the final kind of tip and trick, especially for the healthcare providers online, sometimes with a medical director, if it's really kind of pushing the envelope on the the approval of that therapy for what you want to use. So say it's approved for ulcerative colitis, but you want to use it for Crohn's, and they've been on many other therapies. I'll sometimes say, just give us 6 months. Give us 6 months of this therapy or of what they initially denied for the insurance company, just to see if there's benefit. Because really, if there's no benefit after 6 months, probably we wouldn't push forward with that therapy anywhere. Where if there is benefit, then I think it lends to that next discussion on, look, they've finally gotten better. Can we proceed forward? So just another thought.
Miguel, I just want to add one more comment to you with that. When you are setting up that peer-to-peer, try to make sure that you can actually get a gastroenterologist, because, you know, they're clearly practicing, they understand, you're not like setting, like you're not explaining basic 101 concepts. So if you can really connect with a gastroenterologist that represents the insurance company, then I think your chances of getting approval are way higher than speaking to a doctor that's practicing in family medicine or internal medicine. So
and we'll I agree. We'll try to be careful in how I say what I'm about to say. I completely agree. Although I will tell you, sometimes even with that, we don't get a gastroenterologist that we speak to, and we have to do the best we can explaining. But absolutely 100% agree, and I think it smooths the process. Katie, I'm going to ask a question on indeterminate colitis. So just for a kind of a bread and butter definition, when we say indeterminate colitis, what does that mean?
So I think we try as much as we can to put things into buckets, especially because it can help with insurance approvals if you're looking for something that's approved for one versus the other. And so for ulcerative colitis, you're looking for something that starts in the rectum, kind of goes some length of the colon, and potentially can have a little bit of pushback into the terminal ileum. For Crohn's disease, you're looking for something that has skip lesions that you see about 30% of the time, granulomas on path. And then for me, if I'm having trouble really distinguishing, I'm not sure which bucket it falls in, that's when I'll put it in the indeterminate colitis bucket. And often over time, those patients will sort of declare themselves as one or the other.
Yeah, and I think to your point, over time, a lot of times we see this in our pediatric patients, the younger patients. And I think our pediatricians even now tend to favor the term indeterminate colitis because as the child kind of matures and grows, sometimes we'll see changes that look more like Crohn's and others ulcerative colitis. The only problem is, as we've all said, sometimes getting something approved for indeterminate colitis is not on label. So we have to pick Crohn's, like you said, Crohn's or ulcerative colitis. And I think, as both of you said, really inflammatory bowel diseases is probably a spectrum of like 30 diseases. Even though we say Crohn's and ulcerative colitis, and we try to simplify, and I think both of you are saying the same thing, simplify it in buckets. There are lots of variations within each of these processes. It's just right now based on our what we call our billing codes, ICD-9, ICD-10, and FDA labels, we have to be very specific with names. So even though that's a bit artificial, I think we're seeing more and more, especially as we get into precision medicine and molecular biology understanding of diseases, it's really a spectrum of diseases. Shubha, I'm going to ask you a question on pregnancy. I'm going to ask it two ways. The question that was asked are thoughts on interleukin inhibitors, IL-12, IL-12/23, so risankizumab, ustekinumab, and then the next that comes out in pregnancy. But maybe to expand on that, what medicines should we not use in pregnancy?
Yeah, that's a great question, Miguel. So to the point about the interleukin, so we definitely have a ton of data for ustekinumab use in pregnancy, and we know that at the end of the day, we're actually seeing a lot of this across most of our medication. But at the end of the day, healthy mom means healthy baby, so we essentially need to make sure that mom is healthy to conceive, and that she basically stays in remission during pregnancy to ensure the best pregnancy outcome. So the interesting thing, though, is that because risankizumab is more of a newer medicine, we don't have a ton of pregnancy data in that yet. In theory, you could hypothesize that there's a lot of overlap between ustekinumab and risankizumab, and that being that risankizumab is actually an IL 23 specific inhibitor, so it's not actually hitting more receptors beyond what ustekinumab is. So again, I think in theory, we obviously need more data to confirm this, but I think in theory it should be just to continue, because again, going back to that main point of what we know, we need mom to be healthy in order to have a healthy baby. To that point though, if you do have a patient on risankizumab, consider enrolling them in the pregnancy database. So there's a database ongoing of all the moms that are pregnant on this medicine, and that's a great way to make sure that we're capturing the data that we need so that we can better determine in the future how to continue to use this medicine. So just want to put that plug out there. And then Miguel, in terms of the second question about what medicines we should avoid, so we know methotrexate has been shown to be teratogenic, so we definitely do not want to utilize that in patients that we know are planning to conceive. And then small molecules actually have been shown to also not be safe in pregnancy, and we know that the small molecule can cross the placenta. And so it's really important that if you have a patient that you're actually considering a small molecule therapy for, make sure that you actually are reviewing contraception in female childbearing patients, so that you can actually ensure that there's no potential for pregnancy while they're on the medicine. It is also important to note that there's even a washout period after, so the contraception shouldn't stop right after they end the medicine. It actually needs to continue for even like a month after. So I just want to put that out there, just to make sure that everyone's aware of like the safety concerns around like particularly the small molecules as it relates to pregnancy.
Yeah, and I think the simple way I also look at it is any monoclonal antibody biologic, I now continue in pregnancy, I don't stop, I continue in lactation. And even though your point about risankizumab not having maybe enough data, I still feel very comfortable with that. And I've had my pregnant mom's IBD continue risankizumab, and I think we'll find the data looks very good. Methotrexate, we want the patient mom off for at least 3 months prior to trying to conceive, and to your point about making sure overlapping with birth with contraception. The small molecules, 1 month, at least 1 month. Small molecules are rapidly cleared. Probably 1 month is let's say overkill, but the recommendation is at least 1 month. All right, so Katie, I'm going to ask you a question. The question was originally about using risankizumab off-label for ulcerative colitis, and somebody who's actually failed 4 anti-TNFs. Maybe I'll ask it a little bit differently and say, have you or would you use risankizumab off-label for ulcerative colitis? And in patient who maybe failed for 3 or 4 anti-TNFs, would risankizumab be your next step? So risankizumab off-label you see, and failing TNF, would risankizumab be that medicine?
Interesting. No, great questions. So I think to address the first one, I would probably, if I was going to pick something in that class, go for ustekinumab because it's approved. I think we're going to see more for the IL-23 specific, but not yet. And so I think it would just be easier and more straightforward if I think they're a candidate for that class to go for that. But to the second part of your question, if someone's refractory to 4 anti-TNF agents, especially if they're in that more severe category, I think the data would support you more in going for a JAK inhibitor, and specifically, again, the upadacitinib, just to try to get that patient into remission more quickly. Cycling through 4, they've probably been sick for a while. So you want something that's going to be ideally most efficacious most quickly.
Yeah, and again, I won't even repeat what you said because I completely agree. The risankizumab data for ulcerative colitis, at least early data, looks positive. So there may come a time when it's approved for ulcerative colitis. But if you were to use an interleukin agent today, ustekinumab, if that hasn't been used, but then upadacitinib after TNF is, I agree completely. I think we might have time for one more question. So Shubha, I'll ask you this, and then if there's time, Katie, you and I can chime in. A lot of times our patients, we see them, we talk about getting them into remission. They're in remission. They say, is this forever? Is this the rest of my life? Indefinitely. Kind of what's your answer to that?
Yeah, so I'd like to use one of my attending positive phrase, which is until the next better thing comes along. But yes, we do maintain treatment definitively, and the reason why is that we are very interested in de-escalation, and we are doing studies around like at what point is it safe to stop treatment. But we unfortunately know that inflammatory bowel disease, it can remit and recur. So once you get a patient in the control, that doesn't necessarily mean their inflammation is gone. It's just being controlled by the medication. And so while there might be a proportion of patients that actually can come off treatment and somehow still do okay, we're not at that level of understanding to know like genetically or molecularly what type of patients those are. And so I think just to be on the safe side, especially when we consider like medications like anti-TNF, they have a high risk for immunogenicity. So it's something that we don't want to necessarily chance the boat, stop the patient just to try to get them off and then want to use it down the line when we know they had a great success, but then they develop antibodies and then now the whole class of medicine or that medicine can't be used. So I think just in summary, it's just safe to, if like patients are amendable and like they're doing well on treatment, why rock the boat? Let's just keep them on it. Let's just keep them healthy and in remission. And then hopefully one day we'll find a cure and that'll be the end of it. So
yeah, always, maybe that's a great way to end. We're always striving for a cure. And the only thing I'll say is initially, obviously, patients might be scared about going on these advanced therapies, as we've been talking about tonight. And sometimes I'll say, look, let's break it down into short time periods. Let's break it down to the first 3 to 6 months. Let's get you better. Let's then get it a year. We'll do another colonoscopy. And if you're in remission, let's talk about it then. But mentally plan and prepare for the long term. I think the word forever, and definitely sometimes that kind of is like, this is going to be very scary. But you're absolutely right. I do the same thing. But with that, I first want to thank Katie Falloon and Shubha Bhat for joining me tonight. And on behalf of the Crohn's and Colitis Foundation, this has been a wonderful program. I can tell by your questions that this is a very engaged and informed audience. But we look forward in the future to more Crohn's and Colitis Foundation programs. Please send your information or requests to Crohn's and Colitis. Check out their website, as Shubha had said a couple of times. But we hope everybody stays safe and well and have a happy 4th of July. Good night.
Good night. Thank you.